everyone. Thank you for joining us today for one of our compliance and transaction-related webinars through our hospital webinar series. If you have not joined us for one of these in the past, we focus on different regulatory or transactional matters about every quarter. And if anyone on the phone is not familiar with the team here at McGuireWoods, Tim Fry and I sit in our healthcare department where we spend a significant amount of time focusing on physician and hospital relationships. McGuireWoods as a whole is a 24 office, 1,000+ attorney law firm, and we spend 100% of our time on healthcare matters. Tim spends most of his time related to regulatory matters impacting our physician practice clients, our hospital clients, and other providers and suppliers in the space. And my name is Kayla McCann Marty, and I spend most of my time working on various transactional issues, hospital and compliance considerations associated with large sales or other acquisition activities. So thank you so much for joining us. I think most people probably saw when they registered for the event that CLE will be offered. You should have been asked to provide your CLE information when you first registered. If for some reason you are not sure if you provided it or if you have questions, please feel free to reach out to Tim or I. Our contact information will be on the last slide. So with that, let's just jump right into our agenda here. So we're going to spend some time today talking about a few key healthcare laws. As you'll see here on the slide, the anti-kickback statute, physician self-referral law, known to most of you as the Stark Law, the False Claims Act, and various overpayment, refund, and disclosure requirements. All of these are federal laws, and we're going to spend the bulk of our time talking about examples that impact federal law because we have a number of people from a number of different states on the call today with us. But just know that many of the states in which each of you operate have very similar state laws that apply not only to governmental payers like the federal laws do, but also to commercial payers. So after we get done with that brief overview, we're going to spend the bulk of our time talking about physician compensation hypotheticals. So things that we believe that you really are experiencing either as a physician practice or as a hospital or health system, and hopefully we can give you a few practical things to take away based on those hypotheticals, as well as some additional compliance considerations that we have seen. So with that, let's just jump right in to the overview of the anti-kickback statute. For most people on the phone, this is going to be a very familiar federal statute. It is separate than the federal Stark Law, and in many ways it's dwarfed as compared to it because it really is a much broader law that has a lot broader implications than just providers of designated health services like Stark. So for most of you, you're aware that the anti-kickback statute prohibits the payment and exchange of anything of value if anything is a purpose that would be to induce or otherwise reward referrals. So any kind of gifts like what we're showing here on the screen would apply for any government-funded healthcare services. So like I said earlier, this has a broad application, much broader than Stark. All people or entities could potentially violate it, and it really will be implicated in many of the relationships that you all have with physicians and health systems and hospitals. Luckily, there are a number of safe harbors that provide complete immunity for arrangements as long as that safe harbor covers every element of the arrangement. So if you fail to meet one element of the safe harbor, that doesn't mean it's de facto illegal, but it does mean that you're not going to be able to utilize that safe harbor for protection. If it doesn't meet a safe harbor, we then go to the question of intent. So is one intent of the arrangement to otherwise reward or induce referrals? And that component is where most of the hypotheticals that we'll talk about today and where most of the OIG opinions surrounding the anti-kickback statute have focused over the years. So we'll try to spend some time on that. Luckily, there are a significant number of advisory opinions, as most of you likely know. So you can make different analogies to your specific fact patterns. They usually are not going to be completely one for one, but it does give some pretty good guidance when you have different physician and health system arrangements. So with that, I'll turn it over to Tim to talk a little bit about the Stark Law.
Thank you, Kayla, and thank you all for joining us today. It's an honor to be with you. This is kind of, for many of you, a 300-level course. You could probably tell us, Kayla and I, the exact citation of where the self-referral law is in the U.S. Code. But you may have colleagues that ask from time to time, and so I think it's always good to start with the basics. Where is it from? And, of course, the Stark Law comes from Tony Stark, genius billionaire, playboy. No, that's not right. That's not where it's from. Well, House of Stark, that's what it is. Game of Thrones reference. Winter is coming here in show. Clearly, that's the. Sorry, it's going backwards now. No, that's not right either. It comes from this man, Pete Stark of California, who's now passed away, representative of California. And while I'm contractually obligated to make at least one bad dad joke in the slide deck for each webinar, Pete Stark's view of the Stark Law is it was really simple. We don't want kickbacks to physicians. We don't want any incentive for referrals. Very simple. Then high-priced lawyers got involved, and the book is now more than a phone book. It's more than multiple phone books containing everything CMS has ever said about the Stark Law. So to his point on being very simple, and I promise limited number of future dad jokes in the slides, I can't help myself from making a few off the cuff, though, so apologies in advance. This is how he had in mind. If there's a physician, if there's a DHS entity, any entity providing one of 10 designated health services, including inpatient and outpatient hospital services, referrals cannot be made if a financial relationship exists, unless an exception applies. Strict liability, if you violate it, you have a civil issue where you have potentially an overpayment. Kayla will talk about what happens when you have overpayments. But the Medicare rule is that you're not allowed to bill for the service. And so there are some specific, exceptions, 40 of them, that are either service-based, ownership-based, compensation-based, and you need to meet them. And then there is less case law and advisory opinions than the anti-kickback statute, as probably many of you know, but there is a lot of CMS discussion about what they mean, and it continues to evolve. Every year or two, there are new, kind of changes to the Stark Law and interpretations coming from CMS that they're publishing in the hospital rules or the physician fee schedule rules. And then, as many of you probably know, in 2019, CMS published kind of in 2020, they published a major modernization rule that took effect early in the Biden administration. So you have kickback, you have Stark, and then when we're talking about kind of compensation, to turn it back to Kayla, one of the things we really worry about then is false claims.
Great, thanks, Tim. Just going forward here for a summary of the False Claims Act. In many ways, the False Claims Act ties together the anti-kickback statute and Stark. And so you can see on this slide, we've included a brief overview of what the False Claims Act prohibits. And it was, many of you may not know, it was actually enacted originally in 1863 by Congress when they were concerned that suppliers were actually defrauding the Army. It was never intended to be originally related to health care. But in the last decade or so, there's been really a strengthening of the False Claims Act to be in a position where the government can use it fairly aggressively and whistleblowers can use it fairly aggressively in order to target potential fraud or potential violations of certain healthcare laws. And specifically, the Affordable Care Act amended the FCA to indicate that either an anti-kickback statute or Stark violation can constitute the basis for a False Claims Act action. And so what does that mean practically? First, it increased significantly the potential penalties involved for a violation of the anti-kickback statute or Stark. You'll see here on the slide, we've included a brief example. If you had 1,000 lab tests for $75 reimbursement, you can see in each of these bar graphs what the penalty would be if you just had to repay the collections that you received that you were not entitled to receive versus the potential penalty if you either have a Stark settlement only or FCA exposure. So that's just an indication of how this law really magnifies potential risk. The other component that really magnifies potential risk is that either the government or private individuals are entitled to file suit on behalf of the government. And many of you will know that as a key TAM action, and it really incentivizes people to report potential violations because if a whistleblower is successful, they can receive up to 30% of the amount recovered by the government. So as you can see, a simple violation of the anti-kickback statute or Stark, when bringing in the False Claims Act to that potential fact pattern, could really increase potential risk. And then obviously also there could be a penalty of exclusion from Medicare or Medicaid programs that can be very significant for any physician practice or health system or hospital. So with that, a lot of people ask us, well, how do we discover these different situations? How can we be in a position to refund when we become aware of wrongdoing or inadvertent overpayment? So we really look primarily to the overpayment rule. And so under the Affordable Care Act, it requires providers and suppliers to report and return any amounts that they receive from a government payer, so Medicare or Medicaid, within 60 days of the date that that payment is identified. And the number one question that Tim and I receive is, what does it mean to identify an overpayment? And the government has been fairly clear. It's not 60 days after you think potentially there possibly could be an issue. It's a situation of 60 days after you do reasonable diligence, you determine that you have actually received an overpayment, and then you've quantified the amount of that overpayment. And the ways that we typically see this come up are internal audits can obviously typically find overpayments, or if you're going through a transaction and going through a QOE process or something like that, you often will see these situations come up. So when they do come up and when you do have identified an overpayment or a potential issue, what are your options to try to mitigate that potential risk? So many of you have probably gone through or been privy to a potential self-disclosure. There are two main types of self-disclosures. One is a CMS self-disclosure if you have a violation of the federal Stark law. If anybody on the phone has gone through this, it is a very long process. Sometimes the government will not process them up to 5 years. It also typically results in a smaller settlement than an OIG self-disclosure. We're seeing anything from 5 to 15% of the amount at issue, depending on the fact pattern involved. And then the other option is an OIG self-disclosure, which has some advantages and drawbacks. It can be used for an anti-kickback statute in any other violation. It provides a broader release. It provides a scenario in which it is quicker to have certainty in settlement, but it also results typically in 1.5 times the Medicare dollars at issue, so the potential penalty is often much higher. Just as an example on timing, we recently did a self-disclosure for a client related to an OIG self-disclosure, and it took around 12 months to get it completed with the OIG. So compared to 5 years on a CMS self-disclosure, that is relatively quick. I'll turn it back to Tim.
Thanks, Kayla. We're going to go through some hypotheticals because it's more fun, or hopefully it's more fun, more interesting for you all. And I'm going to go through a first couple pretty quickly because I think many of them are probably in a place based on the attendee list that you probably don't need us to go through. But it's hopeful to start with a couple simple options because we'll build on them, but also make sure everyone's, again, on the same page. So the first example we have here, medical office building that's owned by the health system, wants to lease it to a physician group, very vanilla. This isn't something compliance needs to worry about. Tim and Kayla, you wouldn't be worried about it, correct? It's vanilla, can't get any more streamlined. We own a medical office building. Of course, we lease it to physicians. And the basic answer is, yeah, that's why we're here. That's a financial relationship. There are leases in place all over the country by physicians and health systems. I'm not suggesting by any stretch that's problematic in and of itself. But you have to think about these laws. These laws are asking the question, are you entering into this lease to capture referrals? For the Stark Law, technical strict liability, have we met the exception for the rental of office space? Have we set things up in such a way that we've got a problem? And in here on, kind of bullet 3, there was free office space being provided in an Oklahoma City hospital to a physician group and its management group, as well as personal use and in not paying for it, not meeting the exceptions, and it led to a $70 million plus settlement with the government, with the Department of Justice. So yes, vanilla. Am I going to worry about this very much? No, as long as my client has put in place the lease, has checked the boxes, has been thoughtful, made sure rent is fair market value, so there's no referral incentive. So we're going to go to example 2, basic same facts. But now instead of renting directly from the hospital system, the hospital has set its medical office building through a real estate subsidiary and kind of asked the question here, that's form over function, right? The hospital solely owns the real estate company. We don't have any changes to the analysis with respect to the kickback statute in the Stark Law, right? And here's where the Stark Law starts to get highly complex and takes time, and why we end up spending time looking at the entire phone book. Likely, if there's a Stark relationship here, it will not be what we would consider a direct relationship where you would need to meet the rental office exception, but instead an indirect relationship. So what do I mean by that? I mean an unbroken chain. So if I just show that diagram again, assuming the slide stuff is working, you have the group, which at least the physician owners will likely stand in the shoes of, real estate subsidiary owned by the hospital, and that becomes the indirect relationship that then referrals are going from the group to the DHS entity. In order to have an indirect compensation arrangement, it's not enough to have just an unbroken chain. That's the first item. You need these other items, assuming I can get slide 11 to stay up, that includes aggregate compensation varying based on the volume or value of referrals. If it's a fixed monthly amount, probably not going to meet that. But if it's per day, a per diem, it might, right? You may have a situation where that rental on days is going to base on referrals if referrals would kind of change how often the space is used. So again, it becomes a little bit more factual, even though it still seems pretty vanilla, as soon as you've done something simple like just having a real estate subsidiary. By the way, this slide has changed the most in probably the last 3 years. the modernization rule changed how you did indirect compensation. And then they turned around CMS in 2021 and realized, oops, we forgot about kind of per click leases. And then they added more here. So it complicates and it changes. But it could still be a kickback issue. Even if we took the position this is not even an indirect compensation arrangement, if the reason you're doing this lease and you don't have the right protections in place to meet the safe harbor and all the elements, including a written lease, fair market value, et cetera, kickback statute doesn't have to worry about all those different elements, and it can ask the question that Kayla set up at the beginning. So that's why, again, these two laws can go hand in hand and really leads to some different factual questions. So let me go to example 3, and then I'll turn it back to Kayla for a few more examples. And here on example 3, we've got a situation where we're trying to hire some oncologists as a hospital, and the business team finds out that today the oncologists are in a group practice. And as part of their group practice, they're sharing in their prescription drugs that they're selling and prescribing to their patients right there in their practice, as well as lab revenue. And that's been a key profit source for the oncologists. And they want to keep that. They don't want to see a loss in kind of that specialized drug revenue or those lab tests that they're doing all the time. And the business team says, well, if you're doing it today, we'll do it tomorrow. Let's keep it together. The salary, even with this, is going to be less than other offers they're getting on the market. But because you're willing to do drugs and lab testing, they may say, hey, let's go with you and not this higher salary offer. Is that a concern? And the answer is likely yes. So on your screen, hopefully, if slides are working correctly, you should be seeing a settlement from the mid-2010s with a Florida health system that was making payment to oncologists, including their drug and lab revenue as employed physicians, and it led to a $85 million settlement under the Stark Law, and had to do with something that even if the group practice prior to hiring allows it to happen, maybe the hospital cannot. And so on this slide, you'll see kind of two different things, and we put it here because on that prior settlement, they only alleged Stark violations. They didn't settle on kickback, and the reason very well may be, hopefully what you're seeing underlined, which is that the kickback statute's employment safe harbor is very broad. It includes any remuneration for services in furnishing services payable by a federal healthcare program. And so in that prior example, there's probably a pretty good argument you're employing the oncologist. Kickback statute doesn't prohibit you, especially if they're doing the drug injections, from making those payments. Whereas the Stark exception requires fair market value that's underlined. It also requires that you not pay in a manner that takes into account the value or volume of referrals. And so here's a situation where typically kickback is very broad with narrow safe harbors, but for employees, the reverse can be true. And when you're employing physicians, you really want to be careful to kind of check these boxes, think about fair market value, make sure the bonuses aren't tied to referrals. Kayla, do you want to move on to kind of, by contrast, independent contractors?
Sure, absolutely. So the most common independent contractors that we see in the health system context are medical directors. So in this hypothetical, a physician group has provided a medical director. They've served as a 1099 independent contractor, and they've been there for a long time. During the time, responsibilities has changed. Sometimes they've increased, sometimes they've decreased, and the doctor in charge as the medical director has also shifted. In this hypothetical, the hospital has never amended the contract, audited, or monitored to ensure that the services are being provided. In this hypothetical, the compensation has remained consistent, consistent with typical practice, a fair market value opinion was obtained prior to entering into the arrangement. So you'll see this hypothetical has a 1099 independent contractor rather than a W-2 employee. So we're really in a situation where the various personal services rules under Stark that Tim was referencing earlier are going to apply. And so one of the really key elements here that you all are probably very aware of is the arrangement must cover all of the services provided by the contractor. Here you'll see in this fact pattern, the responsibilities have shifted. This may be something where we would need to know whether or not there really has been a change in services and if those services are supported by the contract, whether they were ever documented, and making sure those services still came into play when the fair market value was obtained. Because if not, we could be in a situation where either all of those services are not included or the fair market value that was originally obtained doesn't contemplate those services. So even though the arrangement may have been perfectly acceptable at the time in which the agreement was entered, changes in practice and administratively not reviewing the contract could result in a potential issue. So when it comes to protecting independent contractor arrangements, we've listed here the AKS safe harbor and the Stark exception. And you'll see with some of the language that we've underlined, there's really a couple of places that it varies. And you'll see particularly under the AKS safe harbor, it requires a significant amount more than what we had under the employment structure that Tim was just describing. So we need to make sure we always have a writing, we have a signature, and we'll talk about signatures a little more in a little bit. We have a 1-year term, and then fair market value with no impact as a referral source. And so as we have shifts in practice, we need to constantly make sure these are being monitored, because it can apply at one time, but due to change in business and not administratively re-reviewing, that can change and be a potential problem. So when have these things come up? Here is an example of a situation in which in Massachusetts earlier this year in June, there was actually a $4.7 million settlement to resolve False Claims Act violations. And basically what the government alleged was that services were not performed as outlined, or they were required to be provided and they were not provided. And so this happens fairly frequently when a contract is entered into and put on the shelf. There's very likely or not originally bad intentions by the parties, but because they were not reviewing documentation regularly, they ended up with this fairly high settlement. So we really just encourage all of our clients and all of our contacts to have a good program to review these various arrangements, because it can result in pretty significant penalties if roles shift without re-examination. So moving to the next example, same fact pattern, but let's say that call coverage is now a portion of that medical director agreement. So it's a combo call coverage agreement and medical director agreement, again, as an independent contractor. In this fact pattern, the group had struggled to recruit an additional physician, perhaps someone retired or moved out of the area, and so a few times they're unable to maintain call. Health systems, from a patient care perspective, need to make sure that the coverage is provided, and therefore they provide an employed physician to cover vacations, occasional situations here and there. However, they don't revisit the medical director agreement and call coverage agreement, and there are no changes to any compensation. Do we have any concerns here? Likely yes, because on its face, it appears that the health hospital or health system is helping to support patient care, make sure that call coverage is covered. But in reality, what they are doing is making available a potentially free resource to the group for call coverage, because the group is still being paid for those call coverages in which they are not provided. So if there had been a change in compensation, a change in role, a change in required services, that may mitigate this particular fact pattern. But in order to do so, the agreement would need to be revisited when these changes in circumstances occur. And so we typically advise to really look at situations in which there could be a change in circumstance, things that commonly occur like departures or vacations, and put in place policies to make sure you're able to deal with those when it comes to free services of any kind, equipment, staff, space, or support. That will put you in a position where it is less likely that you're going to have an administrative footfall here that could create potential liability. And in fact, hopefully on your slides, you'll see earlier this year, there was a settlement by a health system that agreed to pay $3.8 million to resolve potential kickback-related False Claims Act allegations in New Hampshire because they had, in fact, paid for vacation coverage for one of their groups that was providing call coverage. So clearly here, probably good patient care, making sure that there was call coverage available, but they neglected to go back and look at the arrangement and deduct that service that they were providing to the group from the amounts that the group should have been owed. So just the takeaway here again is minor issues can really lead to large amounts when physicians' referral sources are involved, particularly with health systems due to the high volume of referral relationships many physicians and communities have with their local or regional health systems. The next example comes with amending physician PSAs. So I'm sure that nearly all of you have PSAs with each of your affiliated physician groups. So in this fact pattern, there's a 3-year term on a PSA that provides the hospital compensate the physician at $250 an hour, and then everybody wants to amend the agreement to increase physician compensation at some point during the 3-year term. Yet there are no changes to the services. Is this a problem? Can it be done? The short answer is maybe. It depends on the specific facts and the specific circumstances, but you all are probably all aware that amendments are very common. But there's a few specific Stark Law considerations that we want to make sure that you all are thinking about as you consider these type of arrangements. So one, first and foremost, is always the new rate must remain fair market value for the services. So there needs to be a situation in which there is a justification for the increased rate, whether it be services, change in cost, change in the market. The safest approach is always, anytime there's a change in compensation, to go out and get an updated valuation to make sure that it's still supported. And anytime an amendment occurs, it still needs to meet all of the elements of the personal services exception to Stark that we reviewed earlier. So re-reviewing each of those elements at the time of an amendment is good practice. And you're probably aware that the compensation has to be set before the furnishing of the services. So if there will be an amendment to the fee structure or the amendment to the services, making sure that that occurs prior to the services occurring that are subject to that amendment is critically important. That's Stark. Some people also have questions or confusion around the anti-kickback statute because the anti-kickback statute has a slightly different provision that says that the compensation methodology paid to the person in this situation would be required to be set in advance prior to the term. So in the event that you have an amendment, it would be best practice to have the beginning of the term restart at the beginning of that amendment to be in a better position to be able to utilize the potential safe harbor. So with that, I'll turn it back to Tim for example 7.
Thanks, Kayla. So another probably basic example that some of you all may have seen, but you're probably familiar that there's a recruitment exception to the Stark Law. And because of that, CMS was asked and then issued a regulation to allow retention exceptions. And so I'm probably previewing it a little bit. But just to give that background, the recruitment exception allows you to bring physicians from outside your service area and help subsidize them establishing their practice and move to the community, use your hospital, use others, and really strengthen the community need. So people kind of said, well, we've recruited this person, 3 years comes and they could be recruited out of our community and go to another hospital. How does that make sense? Doesn't that just mean we're kind of constantly doing recruitment arrangements? And so you have a situation here, our example, physician on the medical staff has that offer to move out of state. You want to match it. You want to keep them. Can you do anything? And in the slide deck is advanced, I think, potentially. So while the recruitment exception doesn't necessarily have the same prohibitions, the retention agreement does. It requires a health professional shortage area. It requires a bona fide recruitment offer from an unrelated hospital or FQHC that's going to move them outside the geographic area. It has certain requirements on the repayment or forgiveness if certain things happen. It requires, the basic stark things of it being in writing, signed by the parties, without referral conditions, etc. So there is an avenue for you to match Dr. Susan's offer, but you have to check a lot of boxes and work with your business team. For those hospitals that are not in a HPSA, you could consider the employment exception. It would require fair market value, but could you kind of fit that within employment, at least part-time? Could you do it as part of a professional services arrangement? Again, that will require fair market value with some type of bonus. So I'm not suggesting those are wins, but there may be other ways to kind of match the offer in some way, even if the retention agreement is not available. Regardless of whether it is or it's not, the kickback statute doesn't have a comparable safe harbor. And so here, things like community need assessments that I know a lot of systems do for tax purposes might also be helpful here. You're not doing this for their referrals. You're doing it because this specialty is needed and you don't want to see them leave the community. Of course, there is an element of, kind of maintaining your medical staff as well. And so all of those things need to be kind of thought through. And because the kickback safe harbor is not kind of a comparable safe harbor, you probably want to tell your business teams up front if they're thinking about something like this. Let's talk. Let's be very careful. Let's not put in writing how many referrals this provider brings to the hospital, things of that nature. Things you probably do already, but at least if you're like some of the clients I work with, our business teams can always be kind of reminded of some of these items, especially at the beginning of these discussions. So I'm going to move to example 8, and this is the reverse, recruiting someone. And you probably know, famous or infamous, depending on what side of the aisle you're on, Dr. Anthony Fauci is on the market. He's leaving government service. He is going to have to spend some time testifying on Capitol Hill next year, I think. But he's available, and he's whatever you think of him, he's kind of one of a kind. No one else has worked the time he has in the agencies he has. Your hospital system thinks it would be wonderful to recruit them. Medical group thinks the reputation's worth it. They start to offer 8-figure salaries for someone who might make just, a few $100,000 in billing because he's going to be on a speaking tour. Is there any defense of this? Could you possibly say this is okay when we've talked about how employment needs to be fair market value for the stark exceptions? And maybe it is. Your typical pediatric, physician or your typical trauma surgeon, no, you probably can't pay $100 million a year, but someone like Anthony Fauci, would it be commercially reasonable? I don't know. Is he going to be such a big name in the Chicago market where I sit that you help the health system overall with reputation and strategy and whatnot? Perhaps. And if it is, maybe you could defend it as commercially reasonable. CMS has said that it can be commercially reasonable even if it doesn't result in profit for one or more of the parties. Obviously, I think Dr. Fauci at 8-figure salary might make a profit and more salary than he had as a government servant. As we talked about earlier, the kickback safe harbor doesn't require fair market value, although many of you on the line work for nonprofit health systems. You certainly are going to have to worry about private inurement rules if you had this situation. So there are other things that always come into play. But on the fraud and abuse issues that we were asked to talk about today, you may have some ways to defend it, even though this would obviously be outside of any VMG or MGMA. It would be off the charts. But this doctor may be off the charts, and so there may be a way to defend it that way. Kayla, I believe I'm turning it back to you for example 9, but please correct me and I can keep going if I'm supposed to pick up.
Nope, we're good. I'll take this one. So the next one is maybe one of the very common questions that we get, which is, what if a physician forgot to give us their signature page? So late signature pages used to be an issue that would be daily discussions among health systems. The government has softened some of their commentary around signatures as of late. So under this hypothetical, a physician has agreed to be a medical director for the hospital. They've agreed on terms. Everyone has solidified what the agreements will say. The hospital signs the agreement, and for some reason, the medical director just doesn't sign or forgets to sign before they begin work. Is this a problem? Under Stark, likely no. It's always better to get signatures first, but Stark recently enacted a 90-day grace period for obtaining signatures as long as the underlying arrangement has been agreed upon and it was only a clerical error that the signature was not obtained. One thing to note, though, this does not apply to amendments. So to the extent that you believe it does, please update any policies, because that's something that is a problem under the signature commentary that's recently come out by the government. So like I said, the compensation still needs to be set in advance. We need to make sure that all of the arrangement meets the other elements of the applicable safe harbor. But if you're just missing a clerical signature, that's no longer going to be fatal. E-signatures are fine, so DocuSign is good to go for the government's purposes. One thing to note, though, is the anti-kickback statute doesn't have the same flexibility based on the updated rules that have come out under Stark. So you do arguably need to still have a signature in that situation, although obviously we would look at the intent situation here if that signature did not apply. Moving on to the next example are relationships between health systems and immediate family of physicians or other referral sources. So in this example, a physician's spouse owns a flower shop. That flower shop wants to expand. They think a perfect place for that flower shop would be a kiosk in the hospital where the physician's spouse refers patients. The hospital is in favor of that as well because it's currently leased a failed business LLC. They'd like to get a good business into that space. Any concerns? So not likely. In this situation, because there would be a sublease between the failed business and the spouse, it's very unlikely to be a scenario in which Stark would prohibit the arrangement unless for some reason that rent was varying on the volume and value of referrals by the spouse, which we all know is probably fairly unlikely. But this is just included here on our slides as an asterisk. Please remember to look at the immediate family members' relationships in addition to the referral source relationships, because it's fairly common that a immediate family member could also be a referral source or could have a relationship that is also with the hospital or health system, and that can always pose risk, and sometimes it's easy to forget about those. The next is example 11. Tim and I spend a lot of our time looking at relationships that do not conform with the ASC safe harbor to the anti-kickback statute. So any of you on the phone that have an investment in an ASC know that the ASC Safe Harbor is designed to ensure any physicians or other referral sources of the ASC that are financially benefiting from the equity ownership in the ASC are in fact using it as an extension of their practice. There is a policy reason that the government has decided to permit these direct investments in surgery centers in ways that they don't permit direct investments by physicians, for example, in labs or radiology facilities or things more broadly. So we get a lot of questions about this particular area. So in this example, the hospital has identified 10 potential physician investors for a new surgery center joint venture where the hospital is also going to own 5 orthopedics, 5 GIs, 2 neurosurgeons, and 1 OBGYN. Based on running anticipated numbers, the hospital believes that the orthopedic physicians and the GI physicians will certainly comply with the 2 1/3 tests that are included in the ASC Safe Harbor. And you'll see here on the slide, we've included those 2. Most people call them the income test and the procedure test. However, the neurologists and the OBGYNs, because they do a majority of their surgical work on an inpatient basis, they likely will fail the income test. But they are going to still do at least 1/3 of their outpatient procedures at the ASC. Many health systems ask us the question, can we grant a limited waiver to those individual physicians, even though it will technically put us outside of the safe harbor? So the answer is yes, you technically can grant waivers if permitted under your operating agreement, but you'll be doing so knowing that the arrangement will not fall within the ASC Safe Harbor. The goal of looking at these different waivers is really to reduce the risk of having an anti-kickback statute violation when these waivers are granted. So there's a couple of things that we commonly discuss as elements to reduce risk that have been included in several OIG opinions, and then there are some things that increase risk. So if you have a physician that's directly providing medical and surgical services at the center and is going to be substantially involved in its operations, that's always a positive factor. That's going to be something that is good. They're not what we would call a passive referral source. So if the person is a passive referral source, the most classic example being a primary care physician, that person is likely going to refer to other proceduralists that own in the center, but not themselves provide the cases. On a number of different OIG opinions that have been published, the government has been quite critical of passive referral sources owning in surgery centers because they could be in a position where they benefit from distributions associated with their referrals, but they do not themselves use the surgery center as an extension of their practice. So when you have the potential for a passive referral source, even if that person is a proceduralist, you really want to look at a few key components. So making sure that those referrals aren't conditioned on the surgeon performing services, making sure there's no pressure for the surgeons to perform services at a particular center if it's being referred by a passive referral source, informing patients of the financial relationship, and making sure you're otherwise meeting the other elements of the ASC Safe Harbor. Although I will say, to the extent that there is a substantial amount of passive referrals that are occurring from an individual investor, we always recommend that that be looked at very closely from a compliance perspective, because like I said, that's been a very hot area of government focus in various OIG opinions. So here's just one example that I'll put up here for you all to read on your own, because we're running out of time here. But this is a recent OIG opinion that involved a hospital, a surgery center, physicians, and a management company. And it's the newest OIG opinion on this particular topic, or one of the newest on this particular topic. So wanted to just flag it for everyone. I'll let Tim wrap up our examples, and then we'll probably be out of time.
Thanks, Kayla. And because of that, please continue to use the Q&A boxes. We've tried to respond to some things live, but but if you have questions, please put it there or contact us later, and we'll get back to you after this. So example 12, we've got the same basic facts, but we now have one of our surgeon owners approaching the end of his or her career. The JV would like to start to require 63 and older physicians to sell their shares to younger physicians. And obviously, again, let's put aside age discrimination, state law, and age discrimination, federal law. That's not Kayla and I's area of expertise, although, query whether you're going to have challenges there. Do we have fraud and abuse concerns here? Can we put in an operating agreement eligibility around age? And we have to be careful. There was a settlement here about a year ago, just under a year ago, where in this case it wasn't a surgery center, it was a physician-owned hospital, but there was a requirement to, repurchase shares from those 63 and older, and then they resold those shares to younger physicians. They took into account the volume or value of referrals in that process. So, large settlement, nearly $20 million in Texas about this time last year because of that kind of push. Example 13, this gets into a newer area. Something that a few years ago we may have told you more risk. Now, if I preview it, maybe we're okay. So that's here. You've got a situation where it's your medical staff is using a single screen modality. It leads to false positives. It potentially leads to overtreatment or scaring patients because of those false tests. The hospital believes, medical staff, leadership believes moving to a 2-modality test, less false positives, we'd catch cancer sooner, we'd improve care. But asking people to change behaviors is something that certainly my children would attest is impossible to do for their father. And so can we kind of put something else on the table? Could we say, hey, every time you order this 2-modality test, could we pay you $10? Even though the hospital would probably benefit, is that a payment for referrals? Isn't this exactly what Stark and the kickback statute are designed to stop? And the answer is not necessarily. The Stark Law value-based arrangements exception adopted in the last couple of years, and I'll have a slide on it in just a second, CMS basically gave this example. Kind of maybe you do it over a 2-year transition period to incentivize folks, don't keep it forever, and you might be helping with value-based care. Now, the kickback safe harbors are going to require payer risk probably to do compensation here. So you're always going to have that question of the intent. But a properly designed change of care plan structure, with fair market value considerations for, professional service arrangements or your employed physicians, maybe you get comfortable that you could do this now that Stark has these value-based exceptions. So there are value-based enterprise exceptions under both the Stark Law and the anti-kickback statute. It requires kind of this enterprise approach if you're going to pay money to physicians, the idea being we want more than one provider involved. We're going to target a population for things like care coordination, improved quality, like on the prior slide. Stark Law tends to give you more protection here. For things like value-based arrangements, you can do things like care coordination and get there with compensation under Stark. The kickback statute is stingier. They are going to require some payer risk sharing before you can actually write a check. So there's a lot here. We don't have time to go through, kind of every nuance here, but just know that if your business teams at the hospital are kind of coming up with some of these kind of more creative care coordination changes, there's a pathway that there may have not been in the last couple of years. by contrast, we've got a situation where there's a profit opportunity for a key physician at a behavioral health hospital. You have them as a medical director, and you want to pay a monthly bonus based on the overall profits of the hospital, and you want to pay if the behavioral health hospital ever sells, maybe you want to pay kind of a profit on the sale. And you're not going to have them own for physician hospital ownership rules, but you want to kind of land a bonus that would be kind of like ownership. And yes, and the physician kind of says, look, I'm working as the medical director. I'm full-time at the hospital. I'm probably not referring patients. Isn't this pretty low risk? And the answer is no, it probably does have risk. Kickback statute, obviously, you're making direct payments, compensating with a bonus that, this behavioral health physician probably is in a position to kind of adopt patients, but also under the Stark law. And we'll just kind of end here with kind of a definition of referrals, that a definition of referral under the Stark law includes plans of care. So even though that medical director maybe isn't introducing the patient, if they're in a position of certifying or recertifying the need for those hospital services on an ongoing basis, it probably does meet it. And things like future profit shares, even if it's never paid, is that of another benefit? Well, of course it is. You're not offering it to them if there wasn't a benefit. So there can be those types of issues as well. These couple slides, I had a lot more notes. So if there are questions later, I'd be happy to kind of get there. But let me shift to this final slide. So you have Kayla and I's contact information. Also, one of our colleagues, Alexis Reynolds, who's been a little under the weather and also dealing with a lot of, month-end closings, was helpful, more than helpful in developing this content and presentation. So her contact information is on there as well. There is a lot we know here. We also know we went through a lot of this very, very fast to try to hit a number of different topics, but also introduce, I think you'll see in the slides, some actual real world settlements and enforcement actions to just give you a sense, to remind you, keep you abreast of what's going on, and kind of suggest some places where we think you may find your discussions with your compliance team, with the rest of your legal team, your business folks, just always a reminder as we go into 2023, that these laws continue to exist. As Kayla mentioned earlier on, state laws continue to exist. And if we can be helpful, please don't hesitate to reach out. We welcome talking about these things, and have appreciated the chance to join you today during your lunch hour. With that, I'll stop. But again, please don't hesitate to reach out to us by email, phone, LinkedIn, whatever your mode of communication is. We'd love the chance to talk with you. And with that, I hope you have a wonderful holiday season.